So thank you very much for attending. My name is Maria Alcaide, and I am a critical care step-down dietitian. And I just would like to talk to you today about a case study of a long-stay patient, just showing like the impact that critical illness has on the patient, not only on intensive care, but only like on the ward and once they go home. So this is what I'm gonna speak today, and just a little bit of background that, as we know, that in the previous years, like intensive care survival rates have have notably improved. However, like patients who survive, they do it with very poor quality of life, and this is mainly because of the massive muscle mass loss that they suffer during their stay. And also when they gain weight during the first year, most of the studies have shown that this is mainly fat rather than muscle. So this is why it's really important that all of us, we put in place appropriate strategies within their admission and post-admission in order to minimize the effects and that critical illness has. So I will start with the case study now. This is a 81 years old male that was living with his wife, independent previous before admission and with no nutritional concerns. He was admitted following urgent emergency abdominal aortoiliac artery aneurysm, and as you can see, his medical history was already like quite significant. So he was urgently admitted to the vascular ward, and he underwent an endovascular repair. But following this, he developed bowel ischemia, and he underwent a laparotomy, and they created an colostomy. Then he was discharged to the ward with parenteral nutrition as a nutrition route, and then he was readmitted again to ITU due to a small bowel obstruction and abdominal perforation. Following this, he spent on intensive care 31 days, and he underwent multiple relook laparotomies. He had the abdomen open, and he was invasively ventilated. He went through BiPAP and stepped down to CPAP and trachea mask. As his gut start to work, we started some trophic NG feed, and then on day 42 of his admission, he was discharged to the ward, decannulated, discharged to the ward, and on overnight feed and oral nutritional supplements. And I'm just going to start and focus a bit more on his journey during the war. That is like the main role that nutritional support that I provide. So when he was stepped down, he had category 3 for pressure ulcer. When I went to see him, he was nil by mouth because he had aspiration pneumonia, and his NG tube had come out that day. However, he was reviewed by SALT, who advised to start level 6 diet and normal fluids. So at this point, it was a decision made to try with oral nutritional supplements and orally rather than reinsert the feeding tube. His participation with physiotherapy was quite limited due to pain. Then on day 52, his NG tube was reinserted because he was barely managing like 35 to 40% of his requirements, and it was started overnight feed in order to promote oral intake during the day. Then on day 62, he had a gun infection and his appetite was quite reduced. He was very drowsy, and we increased the feed to 20 hours. Then again, his NG tube came out again, and after that, we advise reinsertion in view of his category 4 pressure ulcer, which were worsening. Also, he got the back dressing of on the abdomen wound. He was very fluid overloaded. His potassium was really high, so we had to change to a low potassium and more concentrated feed. This caused him vomiting. We looked at other causes, but it was the only thing that changed. So we liaised with the medical team and we switched his feedback to the standard one. But the thing that changed was that the diuretics were reviewed. Then by day 78, his abdominal wound showed some improvement. However, because he was having a lot of infections, discussions regarding palliative approach were conducted. However, at this point, it was agreed to continue with the full active treatment. By day 84, his NG tube came out, and again, and he decided that he didn't want to have any more artificial nutrition. So he was feeling very nauseous. We spoke to the medical team to offer some regular anti-sickness 3 times a day, and we tried different nutritional supplements, and finally by day 91 we started to see some improvement on his appetite. He was also reviewed by SALT, which that helped to have easy to chew diet, and meal planners were filled with the patient and the family, and some leaflets were offered to bring food from home. By day 94, he was on 3 different supplements, which he was liking. His appetite notably improved, and his abdominal wound and pressure sores were progressing well according to the tissue viability and vascular nurses. So by day 108, we were able to say that he was managing to meet his nutritional requirements, and was one of the first time that he started to kind of enjoy and be more engaging with therapy. Then he was discharged to a community hospital. So on day 111, he spent 31 days on intensive care and 80 days on the ward. So he came with around 80 kilos, and then he lost a massive amount of weight during intensive care, around 15%, and his lowest weight during the ward was 58, which is a massive difference for sure. Some of that it was fluid, but we will discuss that later. And he was discharged with 71 kilos. We can see that his mid-upper arm circumference and hand grip strength also follow similar pattern that is started to decrease after his discharge from intensive care, and it took a while to start to improve again. So these are the barriers that we encounter to achieve his nutritional requirements. Infection that made him very drowsy, or like, for example, low mood, which affected his low mood due to his lack of independency, which was affecting on the engagement with therapy, and some nutritional impact symptoms like nausea, sore throat. And we can see like what we have done differently. For example, the use of indirect calorimetry, which we are in the process of getting the funding for it. But this is really important because it's like we are working to achieve nutritional requirements that they are predictive. So it's kind of working in the blind. We didn't use any nutritional assessment tool which can help to improve the consistency on our practice. And I think it's really important that we don't chase like any metabolic endpoints, because it doesn't matter if we are going to try to aim for 30 calories per kilogram for the patient to achieve if they are not able to meet even 20. But despite this, I think we need to focus our care on patient outcomes and see, like, are the wounds improving? Is the patient like with improved level of energies during the therapy? Are they eating a bit better and feeling stronger? However, I think that having something like indirect calorimetry, even if it will tell us kind of those endpoints, it will make for us easier and faster to be able to see those improvements in the outcomes. I think also we should have early liaise with the MDT and ensure mental health involvement, which it wasn't included or involved with this patient, and we should have escalate sooner the reinsertion, well, when the patient wasn't meeting nutrition requirements, and maybe since the first moment that he came to the ward, to make sure that the NG tube was in place. And also we should have start maybe meal planners and food from home leaflets before, since he was allowed some oral nutrition on the first day that he was stepped down to the ward. So the outcomes for this patient, like during this admission, it was really positive because he progressed from PM to full oral nutrition. His weight improved from 83 to 71. So 83 went down to 58 after intensive care and then improved to 71. Mid upper arm circumference and hand grip strength, as well as abdominal wounds, all improved, and this patient was transferred to community rehab hospital. However, unfortunately, he was readmitted 1 month later due to gluteal abscess. He was for 31 days on the ward. He was discharged home, and 2 months later, he passed away. So I think this is linked with the relatively linked with the importance, no, like of keeping the NG tube. I mean, I'm sure that nutrition is not what made that for sure, but it definitely is one of the factors that will have a big impact on later rehab and recovery phase of the patient. So maybe like if we would have been able to provide that full nutrition during the first stages, because he developed his pressure sore category 2 on intensive care, and then got worse during the ward. Maybe nutrition might have helped to improve like those wounds, or like slow the worsening or minimize the worsening of that, and that might affect his readmission with the abscess in the gluteal and the infection. So I think they are all things that we need to consider, and I think NG tube can help definitely to minimize the effects of nutritional impact symptoms, can also help with the improved level of energy and wound healing, make the patient feel more independent, and that can help also on affect on the mood of the patient. And for example, one thing that it surprised me is that in the one of the last conference from the European Society of Clinical Nutrition and Metabolism, ESPEN, there was this expert consensus, because they recently created this global research initiative on post-ICU nutrition. They are a group from Australia and Netherlands, and they were suggesting that we should keep the NG tube at least until we are 100% sure that the patient is able to meet 100% of the requirements. Sometimes we feel like patient is hitting half of the meal, okay, we can take the NG tube. But actually, I think it might be more helpful if we try to keep it for the effects that we'll have later on. And what actions can we do as a team to help maintaining the NG tube, to swap the tube for a fine board before they are stepped down? Because sometimes when they come to the ward and they have like the 14 or 12 French, which is really thick, I understand that this is very uncomfortable and they want to take it out as soon as possible. And before doing this, I think it's important to discuss with the pharmacist, because some medications are thicker and it might be contraindicated to swap it. But I think definitely that really helps. Then discussing with the patient the importance of keeping the nutrition, the NG tube, and the effects that will have later on rehab, because we need to have clear like that the patient is able to eat and drink, and that they are allowed now to oral intake as per SALT advice. It doesn't mean that the patient is able to meet the nutritional requirements. Sometimes it's like patient is able to eat and drink, but how much is eating? Is maybe eating half yogurt. And we need to consider that after all the stress that they have gone through intensive care, they need a lot of calories, energy and protein. And as a team, we should ensure that the ward where our patient is going to be stepped down, they receive appropriately the copy of the feeding regime to ensure the continuation. And just as reflections, now we are trying to monitor our patients twice a week on the unit. However, we need to think about the practicalities of this. For this patient, for example, with open abdomen wound, it would have been like, is it really worth it, like, to weight him if he's fluid overloaded and put him through that? The stress, is the weight also going to change anything on his care? So we are thinking of introducing other outcomes like calf circumference. And now I'm not sure if you are aware of the new protocol for starter feeding regime, the out of hours, to start forcible, because this protocol usually start with very low rate, and the most likely is that this patient are not going to be able to meet their micronutrient requirements. Then I think it's really important the early involvement of mental health, and also like use focus functional outcomes like the hand grip strength, to see how the functional status of the patient is progressing. However, these have also limitations, like if the patient is low mood, that can affect of the some disease, or like rheumatoid arthritis can also affect this. So I think it's really important that we see the whole picture and see how everything is progressing there, with the recovery. And then finally, like the development of this service, critical care outreach, which is something quite new, and there are only, I think, 2 more trusts in UK which provide nutritional support post-intensive care. So we are lucky and we are able to review patients twice weekly, but we need clear caseload for when these patients really need to be followed in this service, because sometimes they come for ITU like head and neck, they stay one day, and definitely they are not the same risk as those long stay patients that they go through a lot. And finally, I think it's really important ongoing MDT, working together and training, just to show like of how much stress and how much or how big are the nutritional needs at this stage. Here are some references. Thank you very much.
I don't know if anybody has any questions, please shout up. But that was very, it's good to be able, because we once they've left intensive care, we don't get to find out very much about what's happened, but it's a very good illustration of how much impact ICU has on ongoing life, because he obviously lost quite a lot of weight and struggled a lot.
Yes, and I think like some action, a small action, just as that within intensive care can help later on, can have an impact on the world and definitely on later recovery. Because we see patient, he was 81 years old, but we see like very young patients, and I have also my follow-up clinic when they go home that you see, it could be me that they are struggling even to walk because of the significant and debilitating impact that the critical illness has on them.
Yeah, it definitely does. From personal experience, I can say I spent 9 days on intensive care following trauma, and then 5 more weeks in hospital. But when I came out, I remember my legs looked like sticks because I'd lost more than 10% of my body weight at that point. And I was never big anyway, but I'd lost more than 10% of my body weight, and it was all the muscle had gone totally. And I was the fittest I've ever been probably when it happened. So and then it took 2 years to get it back. I've always told patients that they need at least 6 months, but personally it took a lot longer than that. And I tried to be fit and motivated, but
Yes,
yeah,
it's very hard. Like
that's why we have we make decisions about admitting them in the first place, is because of how much impact it has afterwards. And if they aren't going to be able to cope with that, then we don't admit them, because they're not going to be able to get back if they haven't got the physical reserve to get back. But thank you very much, everybody. Thanks, Maria, for sharing. It was very interesting.
You are in for a treat this afternoon. I'm going to talk you through Anderson Ramberg's 2023 critical care look and analysis for haloperidol for the treatment of delirium in critically ill patients. So delirium is an extremely common in the ICU, affecting somewhere between 30 and 50% of patients, depending on how aggressively you screen and the population that you're looking at. It's not just a bit of confusion, it's associated with increased duration of mechanical ventilation, longer ICU and hospital stays, and longer-term cognitive impairment and disability after discharge. Several observational studies have also linked longer episodes of delirium with higher mortality. So it's a serious complication and not just an inconvenience. Despite that, we don't currently have a true evidence-based pharmacological treatment. Recent guidelines explicitly advise against routine use of antipsychotics for the prevention of treatment of delirium, focusing instead on the non-pharmacological strategies. In real life, though, I think it's probably fair to say that many of us still reach for the haloperidol when patients are agitated, distressed, or at risk of harm. And that gap between the guidelines and practice is why this review is clinically important. So haloperidol remains the default antipsychotic for delirium in many intensive care units. It's familiar, relatively cheap, and we're pretty comfortable titrating it. But the previous systematic reviews on haloperidol in critically ill patients with delirium found that the evidence was sparse and inconclusive. So since that earlier review, several new RCTs have been published, including large multi-centre trials like the AID-ICU and Mind USA, and they've added a substantial amount of new data, but individual trial results aren't entirely consistent. So, for example, the AID-ICU suggests a possible benefit to using haloperidol, whereas Mind USA trends more towards harm. So there's a real need for an updated meta-analysis that pulls the data and asks, do we have enough evidence to be confident about the benefits and harms of haloperidol in this population? So very quickly then this slide. So for anyone just joining us who might not be aware of the CASP format, so CASP is the Critical Appraisal Skills Programme, and they've developed some handy checklists to help us systematically appraise literature with different checklists for different types of study. The full checklist also provides notes on the sorts of things we need to be looking at when we are assessing. So, first up then, from a CASP perspective, the review scores quite well on the first question. So the research question is clearly formulated and clinically relevant. This analysis is focused on critically ill patients with delirium already present at the time of randomisation, and that's an important distinction. These are treatment trials, not prevention trials, and trials that only enrolled at-risk patients were excluded. The intervention is haloperidol, either IV, oral or IM, with variable dosing schedules reflecting real-world practice. Comparators to this include placebo, other antipsychotics, dexmedetomidine, benzos, morphine, ondansetron, or no pharmacological intervention, although the primary comparison of interest is haloperidol versus placebo. Outcomes seem to be well chosen and patient-centred. All-cause mortality and serious adverse events or reactions as primary outcomes, and delirium/coma-free days, delirium severity, cognitive function, and health-related quality of life as secondary outcomes. Follow-up is generally 28 to 90 days. And overall, the PCOTS elements, so the population intervention comparison outcome and time or setting elements, are explicitly reported and appropriate for review of the randomised controlled trials in this area. So dipping down then on section B, the basic design is appropriate. It's a systematic review and meta-analysis restricted to randomised controlled trials, which is the correct design for assessing the efficacy and safety of an intervention like haloperidol. The authors followed a pre-specified and published protocol registered on the Prospero registry, which is good practice and helps to really reduce things like selective reporting and analytic flexibility. They state that they adhered to the Cochrane Handbook PRISMA reporting guidelines and used the GRADE framework to rate the certainty of evidence. The search strategy that they used is broad, with multiple major databases from inception to the April that year. They also searched for trial registries for unpublished ongoing trials and screened reference lists of previous reviews. From a CASP perspective of were all relevant studies likely to have been identified, I'd probably say that's yes, because the search is comprehensive and well described. Although the paper doesn't give the full research strings in the main text, these are in the supplementary material. So, for screening and selection, the authors again used a robust process. They included only randomised clinical trials in critically ill adult patients where delirium was actually present at the time of randomisation. This means that they excluded quasi-randomised trials or crossover designs and any studies that were purely observational or focused on prevention rather than treatment. They also excluded trials like Hope-ICU and the Feasibility Mind trial because they enrolled mechanically ventilated patients irrespective of whether they got delirium or not. Two authors independently screened titles and abstracts before then screening full texts using predefined inclusion and exclusion criteria, and disagreements were resolved by discussion with a third author, which is good practice to reduce the selection bias. Overall here, the eligibility criteria are logical, consistently applied, although that you might argue that excluding trials for at-risk patients loses some power and external validity, but it gives a much clearer treatment question. So questions 4 and 5 then go to ask whether the authors assessed the validity of the included trials and whether the data were extracted and presented appropriately. Here, two reviewers independently extracted data using predefined forms and assessed the risk of bias with the Cochrane risk of bias tool at outcome level, which appears to be a strength. It's more precise than other tools, and assessing per outcome matters because different outcomes in the same trial can have different biases. For the analysis, they used risk ratios for dichotomous outcomes and mean differences for standardised mean differences for continuous outcomes. Importantly, they adjusted for multiple primary and secondary outcomes by using a family-wise error approach, which looks at the probability of having at least one false positive across a set of data. So, for example, they used a 96.7% confidence interval for primary outcomes instead of the usual 95, which then tightens that threshold for significance. They perform fixed and random effect meta-analyses and reported whichever was more conservative. And then, as the title suggests, use trial sequential analysis to estimate the required information size and to judge whether the available data are sufficient to draw firm conclusions before then applying the grade framework to review the evidence. From a methodological standpoint, these are all strong features, although the trial sequential analysis is quite complex and the adjustments do make the paper harder to interpret at first glance. So in terms of what actually went into the analysis, the flow diagram shows over 6,500 records were screened with 104 full text assessed and 11 randomised controlled trials with 15 comparisons. So a total of 2,200 patients were ultimately included. The key comparator and the one that we'll focus on most is haloperidol versus placebo, which includes 5 trials. The remaining comparisons include haloperidol versus other antipsychotics, and these include ziprasidone, risperidone, quetiapine, chlorpromazine, and some smaller trials comparing dexmedetomidine, lorazepam, morphine, ondansetron, or nothing specific. Most patients were treated in intensive care units. A few trials also included patients from EDs or general wards. One trial was in a high dependency AIDS unit. Sample sizes range from 10 in the smallest trial to 1,000 in the largest, with mean ages from early 30s to early 70s, with female representation being variable, but generally under 50%. From a CASP perspective, the authors summarised trial characteristics clearly in a table, so I'd say yes for transparency of included studies. Looking at the risk of bias, several of the largest modern placebo-controlled trials, such as the AID-ICU and Mine USA, are judged to be at overall low risk. This strengthens the conclusions for the primary comparison. Some of the smaller or older trials are higher risk of bias due to issues like unclear allocation concealment, inadequate blinding, or incomplete outcome data. The use of the risk of bias 2 tool and grade allow them to downrate certainty of evidence where these issues are particularly important. The overall grade ratings are moderate certainty for mortality with haloperidol versus placebo, low certainty for serious adverse events or reactions, and very low certainty for some pooled safety outcomes, and moderate certainty for days alive without delirium or coma. There's almost no robust trial evidence on long-term cognitive outcomes or health-related quality of life, which is a big limitation given how important these outcomes are for patients. From a CASP point of view, the authors clearly report limitations and use the grade system transparently, which supports trust in their interpretation, even if the underlying data aren't as strong as we would like. So looking at the primary outcome of all-cause mortality for haloperidol versus placebo, across 5 placebo-controlled randomised controlled trials with 1,553 patients, mortality ranged from 28 to 90-day follow-up. Overall, 34.5% of patients in the haloperidol group died versus 38.6% in the placebo group. The pooled risk ratio is 0.89 with the 96.7% confidence interval from 0.77 to 103. And statistical heterogeneity is essentially 0. So this gives a point estimate suggesting 11% relative reduction in mortality with haloperidol. But because of the multiplicity adjusted confidence interval, it narrowly crosses 1 and doesn't meet the pre-specified threshold set by the authors for statistical significance. The trial sequential analysis, which is essentially a way of doing interim analyses on meta-analysis level, shows that the required information size hasn't been reached to reliably accept or reject a 20% relative risk reduction. So to sum that garble up, the current data hints at a mortality benefit, but we don't yet have enough evidence to be sure. This is then rated as moderate certainty, mainly downgraded because of the imprecision. So beyond placebo, the review also compares haloperidol with a range of other drugs, with those 5 trials comparing other antipsychotics. When pooled, there aren't any statistically significant differences in mortality, serious adverse events, delirium or coma-free days, or the delirium severity scores. However, the analyses here are well underpowered and graded as low or very low certainty. Each of the other comparators, like Dextal, lorazepam, morphine, ondansetron, and the no intervention arm, come from a single small trial. So the results are very uncertain and not easily generalised. The trial sequential analyses show that we're well below the required information size to form any comparisons at all. An additional complication is that in several trials, including some of the placebo-controlled ones, patients were allowed open-label antipsychotics, i.e. both the staff and the patients knew what they were getting as a rescue therapy. This likely contaminates the placebo or comparator groups and biases any true effect of the haloperidol towards the null hypothesis, which is important to bear in mind when we interpret the no difference findings. So, pulling together the checklist, then I would summarise the paper's methodology as quite high quality, with some important caveats. On the positive side, the review does address a clear and clinically relevant question, focusing correctly on randomised controlled trials. It's got a comprehensive search strategy using pre-registered protocols and the methods for data extraction, risk of bias assessment, the meta-analyses are state of the art, especially with the risk of bias 2 tool, and we're using the grade system and have explicit control for multiple outcomes. The authors are also appropriately cautious in their interpretation, avoiding saying no difference when the confidence intervals are wide. Instead, they frame their conclusions in terms of what haloperidol may or probably doesn't do, and this emphasises the remaining uncertainty. The main limitations here relate to the underlying trials rather than the review itself. Incomplete or heterogeneous reporting of serious adverse events, with very limited data on long-term cognition or health-related quality of life, along with the open use of other antipsychotics in several trials with large amounts of imprecision, indicates that we still haven't reached the required information size for many of the outcomes. So my overall answer to the question, are the results trustworthy, would be yes, but with a huge sprinkle of caution due to the imprecision and gaps in outcomes. In terms of what this means for clinical practice, firstly, mortality. The pooled estimate suggests that haloperidol may reduce mortality compared with placebo. But the confidence intervals include no effects, and the trial sequential analysis suggests that we don't have definitive evidence. So we can't claim that it saved lives on the current data, but we can't rule out a small benefit to mortality. With regards to safety, the evidence suggests little or no difference in the relative risk of adverse events or reactions compared to placebo. But again, this is based on incomplete reporting, and the certainty is low. QT prolongation appears more frequently with haloperidol, but again, the evidence is sparse and imprecise. So we should just continue to monitor ECGs and correct other risk factors rather than ignore the issue. Haloperidol probably doesn't have a major impact on delirium or coma-free days. We don't have strong evidence that it's better or worse than any antipsychotics or the alternatives, but the comparisons to this are massively underpowered. So clinically, it leaves us in a bit of a nuanced position. If non-pharmacological strategies and environmental optimization has failed and the patient's distressed, unsafe or impeding essential care, then haloperidol, I think, is a reasonable pharmacological option. It's probably the best studied agent with no clear evidence of harm and a possible benefit, but we shouldn't use it on a whim or for prolonged periods without good reason. So there's several points that are worth highlighting for potential discussion at some point. The first, the trial sequential analysis is an important concept. So rather than simply asking whether a pooled p-value is below 0.5, it asks whether the total number of participants and events is sufficient to draw firm conclusions, similar to interim analyses in a large randomised controlled trial. In this review, the TSA shows that for many outcomes, including mortality, we still don't have enough information to be sure, even if the point estimates look promising. Secondly, the grade framework encourages careful language. Instead of saying haloperidol does or doesn't work, the authors use terms like may reduce or probably results in little to no difference to reflect both the observed effect size and the certainty of the evidence, which is useful language for us to think about when we talk to colleagues and patients. Thirdly, the serious adverse event reporting is a chronic weak point in ICU trials. The review highlights inconsistent use of the good clinical practice definitions and likely underreporting. It's a reminder that no reported harm is not the same as no harm. And clinically, fourth, in the contrast between the AID ICU and MIND USA trials, raises the possibility that haloperidol's effects may differ between patient subgroups, such as older versus younger patients, hyperactive versus hypoactive delirium, or ventilated versus non-ventilated patients. Finally, outcome selection is key here. We tend to focus on mortality and the intensive care unit length of stay, but actually for many patients, the more relevant outcomes are cognitive function, mental health, and the ability to return to an independent life, which are outcomes that this evidence base doesn't yet address well. Fifth, do you think there are any specific subgroups in our home intensive care units, for example, where finally, I have some take-home messages. I've been waffling for long enough. So, firstly, delirium is a common and serious complication of critical illness, and we still don't have a proven treatment. The review represents the most up-to-date and methodologically rigorous analysis of data for haloperidol in this setting. The evidence suggests that it may reduce mortality, probably doesn't substantially increase serious adverse events compared to placebo, but the certainty is only moderate for mortality and low for safety. And we still haven't reached the required information size to be sure. The results are encouraging, but not definitive. Haloperidol probably doesn't meaningfully change delirium or coma-free days, and there's very little evidence on longer-term cognitive and quality of life outcomes, which are what matter most to many families and their patients. Fourth, when compared to other antipsychotics and sedatives, the evidence base is too thin to make any strong claims about superiority or inferiority. And finally, non-pharmacological strategies should remain the cornerstone of delirium management. So when pharmacological management is necessary, haloperidol is a reasonable option, currently the best study, but we should continue to use it judiciously, monitor for adverse effects, and support the future research that focuses on patient-centred outcomes and identifies which patients, if any, would benefit the most. And thank you for bearing with me.
So what are you going to do on nights at 3 o'clock in the morning when the patient's trying to get out of bed?
Give
Not
haloperidol.
to listen to anyone. Fair enough. Because you've clearly done quite a detailed dive through and having a look around at the literature and stuff. So.
And there's nothing strongly supporting for or against, really, is there? So I think needs must in the haloperidol situation is probably still the go-to line.
Yeah, and you're right. Try and talk them round or work out what the problem is, treat their pain, treat their constipation, give them their hearing aids or their glasses so they can understand what the hell is going on. That kind of simple stuff first. But yeah, if it's not working, then I suspect we'll never really get evidence, because you're right that we're looking, it's hard to measure out kind of quality outcomes beyond mortality and length of stay, which
because
are nice and easy.
Too many confounders outside of that after you leave the ICU setting, I think, to be able to get a meaningful measure. Yeah,
totally. It's a ongoing problem with ITU trials, unfortunately. You just have to try and do individualized care, work out what's best for that patient, try something, and if it doesn't work, try something else, which is frustrating, but it's just all of ITU ever.